So hopefully, if this technology works, we should be going live on YouTube. So when the maximum capacity of the webinar is reached, then all the attendees can then start to go on YouTube. And lo and behold, we are on YouTube live. Excellent. Yeah, we're on YouTube live. Hopefully, if this technology works, we should be going live on YouTube. So when the maximum capacity of the webinar is reached, then all the attendees can then start to go on YouTube. That's funny. It's talking back to me. And lo and behold, we are on YouTube live. Let me just. Excellent. Yeah, we're on YouTube live. Hopefully, if this technology. Okay. That's better. It was talking back to me, that YouTube thing. That's excellent. So we're all set. We just wait till the audience starts. Okay, we can go start. I think we are now live, and you'll see the attendees number will start to climb up quickly. Okay, we'll wait for a few more minutes. We'll just wait for a few minutes. Okay. So while we're waiting, I'll just do some introductions. Okay, I think we got fair number of people joining us now. Still the count is going up, so just wait for a bit more. Yeah, I think this part where you're doing all the electronic bits is quite stressful, because sometimes the links to YouTube don't work, and sometimes all these presentations, they start acting funny. Looks like it's all going well. Okay, I think we should make a start. Welcome everyone to the next session of the Sunday Supper with Wrightington. Today we have a superstar cast. We have 3 surgeons, 3 colleagues from Alderhay Children's Hospital. We have James Widnell, who's got a special interest in neuromuscular aspects of children orthopedics. He's going to be talking about upper limb trauma. Following that, we would have Chris Pryor. He's again a consultant in Alderhay. His special interest is in limb reconstruction and complex trauma. And he'll be talking about lower limb condition, including slipped capital femoral epiphysis. I think I've got that one right. And then we have Chris Talbot, who's again a consultant in Alderhay. His special interest in adolescent hips, and he'll be talking about lower limb trauma. And we joined with Chris Betherton, who's a rep from BOTA. Excellent. We got a fantastic panel. I'm really looking forward to this talk. So the way we'll go like we've done the other sessions. We'll do one talk at a time. If you have any questions, could you please use the Q&A section in the webinar and post your questions over there. So one of the panelists will take the questions, answer them. We'll do the 3 talks, and we'll have some MCQs right at the end. So without much further time wastage, let's start this session, which I'm really looking forward to. James, are you ready to go, my friend?
Yeah, absolutely. Just share my screen. Hopefully you can all see that. Perfect. So good evening. I'm James. I'm one of the fellows at Alderhay. I've been given the task of talking to you guys tonight about upper limb trauma in around 15 to 20 minutes. That's clearly quite a mammoth topic. So I've cherry-picked a few topics that will hopefully come up in your exams and prove useful going forward. What we'll cover is a bit of normal anatomy, We'll then look at supracondylar injuries, we'll look at lateral condyle fractures, and we'll look at Monteggia fracture dislocations. And then very briefly, I'll just mention some big current research projects that are ongoing that you really should be aware of going into your exam. With regards to normal anatomy, you need to know the ossification centres for a child's elbow on a radiograph. Just remember the acronym CRITOL, takes you through capitellum, radial head, the internal or medial epicondyle, trochlear, olecranon, and lateral epicondyle. And remember odd numbers, 1, 3, 5, 7, 9, 11. It's not perfectly accurate, but it's pretty good. And this is a paper from the Scottish Medical Journal in 2019 that shows the images nicely and clear. You also need to know about fat pad sign. The anterior one can be a normal finding, especially if it's parallel to the humeral shaft, but posterior is always abnormal. And this shows that there's evidence of probably an occult fracture that you need to look for if you can see the posterior fat pad sign on the X-ray. So let's move to some pathology. We'll talk about supracondylar fractures. These are the most common pediatric elbow fracture that we see. So therefore, you guys need to know about them because they will be seen in your practice. You can see on that image there how thin the distal humerus is where the fracture occurs. And this is due to a stress riser from the olecranon fossa. And as the child falls onto an extended arm, the olecranon acts as a fulcrum in the fossa and we get this typical fracture pattern. Well over 95% of these injuries are extension type, and about 10% have a vascular injury and 10% have a nerve injury. When you see these children in A&E, you need to make sure it's an isolated injury. If it's in context of polytrauma, then go via that standard ATLS. Make sure the child is comfortable with analgesics. You need to assess their pulse and their cap refill time and the vascularity of their limb, and you need to assess their nerve function. This is an award-winning infographic from an emergency medicine conference that reminds our more junior colleagues listening how easy it is to assess peripheral nerve function even in young children. So it does need to be done. Spin the limb, but don't put it in hyperflexion. That can create problems with swelling. And we want to know if it's isolated, if it's open, and if there's any evidence of threatened skin. With regards to radiological assessment, you're looking at the anterior humeral line, which should intersect the middle third of the capitellum. This will tell you whether there's any posterior tilt or translation. You also need to look at Bowman's angle, which is an average of 72 degrees, but 65 to 80 covers around 95% of the population. And this is an angle subtended from the anatomical axis of the shaft of the humerus and the lateral condylar physis. If there's a 5-degree change in the Bowman's angle, there's a 2-degree change in the carrion angle. And when you consider that one of our aims when we operate on these injuries is to reconstruct the carrion angle of the contralateral limb, this is an important surrogate marker of that. With regards to classification, Gartland classified the extension type injuries into 1 non-displaced and 2 displaced with an intact posterior cortical cortex, and 3 with complete displacement. And this was further subclassified by Wilkins into a 3A with posteromedial displacement and a 3B in posterolateral displacement. But why does this matter? Why is it useful? Well, it's useful when we look at it in the context of periosteum, this wonderful structure that us as pediatric orthopedic surgeons absolutely love. With regards to Gartland 1 and 2 injuries, it can be pretty simple to comprehend. We have a normal elbow, and that the bony architecture is the black line. The green is the periosteum. And in Gartland 1, we've got partial ruptures to the anterior periosteum, but in Gartland 2 injuries, we've got complete ruptures to the anterior periosteum. But our posterior periosteum is still intact, so we can use that as a reduction tool when we flex the forearm up and flex the distal fragment of the humerus to make sure we get good reduction. When we look in the context of Gartland 3 injuries, we need to know a bit more relevant anatomy. There's obviously a lateral side and a medial side and surrounding periosteum on both. On the lateral side lives the radial nerve that goes into the posterior interosseous nerve. On the medial side, we have the brachial artery and the median nerve. And behind the medial epicondyle, we've got the ulnar nerve. Now, when we look at a 3A or a fracture of posteromedial displacement, we know that the medial periosteum is intact. The lateral periosteum is not, it's ruptured. And we know, therefore, the lateral structure at risk is the radial nerve. This is useful because we don't only use it to know what structures potentially are at risk if there is an associated nerve injury, but it's useful to know that the medial periosteum is intact and we can use that as a reduction tool. When we translate this fragment across, that will stop us going too far, provided that we aren't overzealous, and we can use pronation to try and lock in our rotation and tighten up those medial soft tissues. These types of injuries particularly lend themselves to lateral wires to replace that deficient periosteum that's been torn. With regards to posterolateral displacement, we know that the lateral periosteum remains intact and the medial periosteum is now ruptured. That therefore means that the structures most at risk are the brachial artery and the median nerve. And again, it's useful not only from the structures that are at risk, but also knowing that that lateral periosteum can be used as a tool to our reduction. And that supination in this instance will help lock that reduction in. Some surgeons would say that this construct would leave you to have a lower threshold to use a medial wire to replace the stability lost by that torn medial periosteum. You can also apply it to type 4 extension or flexion type injuries, where you can imagine if your distal fragment is flexed up, you're going to have a rupture to your posterior periosteum, and the ulnar nerve is the nerve that's most commonly associated with a neuropaxia to these injuries. I've not put the anterior periosteum on that picture because it depends whether it's a flexion type, which occurs from the original injury, and therefore your anterior periosteum would be intact, or whether it's a type 4 extension type, which is often from iatrogenic overzealous reduction maneuvers in theatre, where we already have an anterior periosteum that's ruptured, and now we've ruptured the posterior periosteum, leaving us with a gross amount of instability and now a very difficult fracture to fix. So when do we need to fix these fractures? Well, grade 1s we don't need to. They can be treated in above elbow plaster of Paris. Grade 2 and 3s, in my opinion, go to theatre and they get K wires. I generally use 2 wires for grade 2s and 3 wires for grade 3s. The BOST guidelines from the British Orthopaedic Association say that they should be going on the same day, ideally, and they stipulate that there's 3 indications for urgent or nighttime operating. They are if there's a white hand or clinical evidence of poor perfusion, that is a genuine emergency, you need to speak to your vascular team and get to theatre. If it's pulseless but perfused and remains pink, then again they would recommend that we go in an urgent fashion. And if there's any evidence of threatened skin, such as that picture, again we should be going in an urgent fashion to theatre. If after reduction, the limb remains viable, remains pink, but there's still no pulse, that child needs to stay in hospital for 48 hours to have close monitoring. We can window the plaster, use Doppler if necessary, but if there's ever any concern about that vascularity to that limb, that child's going back to theatre with our vascular colleagues and ourselves for an exploration and reconstruction as necessary. How do we fix it? This picture shows a theatre setup from Tachidens. The child goes supine with an arm table. The image intensifier comes in from the foot end and allows you to swing the machine through for the lateral so you're not moving the limb. You don't need to use a tourniquet. Firstly, you apply traction in around 20 degrees of flexion, and then you can correct your coronal malalignment, be it varus valgus and translation. You use pronation for posteromedial displacement in type 3s and supination for posterolateral in type 3s. And when you flex that distal fragment up, the hand of the child should be able to touch their shoulder. If you've done that, chances are you've adequately reduced the fracture. I tend to get an idea of my AP trajectory of my first K wire, but then fire it in under control of the lateral image intensifier to make sure that my alignment is good on that view. And once you've got your wire configuration, which we'll talk about briefly, you need to prove that that fracture is stable and take it through a full range of motion to make sure that fracture is no longer moving. So there's always a discussion as to whether we can use lateral wires or cross wires. And essentially there's evidence out there to back up both. However, from my opinion, and as per guidelines, we should always be using 2mm wires when possible. The key is to get maximal separation at the fracture site. And by doing that, you can also get bicortical medial and lateral fix. So you want a wire at the medial column, you want a wire at the lateral column, and that will infer stability. If you have any concern about stability of the fracture, then use 3 wires. You can either put in a cross wire or you can put in a third lateral wire, as you can see in that picture. There was a systematic review in 2015 looking at any biomechanical difference between medial and cross wires, between lateral and crossed wires, and there was none. There was also no difference in a meta-analysis of clinical outcomes. What has been shown repeatedly in the literature, though, is that there is a significant risk of iatrogenic nerve injury with medial wires. So if you are going to use a medial wire, make sure you do it under a mini open procedure and that you document that you use that technique when putting it in. It's not just the case, however, of saying that you're just going to use lateral wires. You need to take into account the bony configuration of the fracture. So medial oblique fractures and high transverse fractures do lend themselves to cross wires to infer more stability to the fracture pattern. As mentioned, the British Orthopaedic Association has put out a standard for trauma for supracondylar fractures. We've covered most of these. Really, the only thing at the bottom that we haven't covered is that we get an x-ray a week post-op, and we take the wires out at 3 weeks. But for any exam, for any BOST guideline, you need to know these inside and out. They're absolutely fair game, and you don't just need to know the standard points. You need to read the document thoroughly. Complications, obviously the pin can move, the pins can get infection. That's thankfully often superficial, but osteomyelitis can occur. Compartment syndrome is something that you need to be aware of, and especially if there's an associated nerve injury, because your examination might be slightly less reliable. And we're fixing these children to make sure that they don't go into malunion, so we want to try and avoid that, be it an extension malunion where they'll lose flexion, or cubitus varus or valgus. So moving on to lateral condyle fractures. This is the second most common pediatric elbow fracture that we see. It's a Salter-Harris 4 fracture pattern. They are often intra-articular, and they have a severe risk of late displacement. So these can be tricky fractures that we need to treat. When you assess them radiographically, you have to get 3 views. You have to get AP and lateral, which is standard, but you can see here that the internal oblique view is the view that details most accurately the fracture pattern that we can see. With regards to classifications, there's a few out there. The original was Jacob, that was in 1975, cadaveric work, where they recreated lateral condyle fractures, and they discovered really that the key to decision making is the presence or not of an intact cartilaginous medial hinge. This was taken a step further with Weiss's work in 2019, where they also used arthrograms to confirm that, and they based it upon whether the fracture was essentially undisplaced, displaced but with an intact joint and arthrogram, or displaced and with a non-congruent joint. Song has also come out with a classification. He's split it into 5 subclassifications and come up with an algorithm for treatment. I think that the treatment can be kept relatively simple. If you are 100% sure that that fracture does not go into the joint and that it's undisplaced, then that child can be treated in an above elbow cast, but they need to have weekly x-rays for the first 4 weeks. The reason being is that because it's so cartilaginous, we cannot be sure on a plain film that that fracture does not extend into the joint. And if it does extend it all the way into the joint, those are the fractures that have a risk for late displacement. The child needs to be in a cast for total of 6 weeks. If you have any doubt over the fracture configuration, then that child needs to go to theatre, they need to have an arthrogram, and that is going to tell us whether the joint is intact, and if so, we can use closed reduction methods with percutaneous pin fixation, or if the joint's disrupted, that we're going to do an open procedure. Clearly, if the plain film at the beginning shows that there's obvious disruption to the joint, there's no need to do an arthrogram, and you can proceed straight to an open procedure. I use a posterior approach or needle into electron fossa for my arthrograms. You need to accept that if you can't get it back closed, that you're going to open this fracture. That's done via a lateral approach, and often the dissection is done for you from the original injury. If not, you can use either the interval described by Kaplan or Cocker. Try and avoid dissection posteriorly around the trochlea. That can lead to AVN. And a good tip that some of the consultants at Alder Hay passed on was that using a dental mirror allows you to get across the joint so you can get good visualization of that joint reduction, because your articular reduction is going to be the key to success in this operation. Fixation methods, you can either use K-wires or screws. K-wires are what I prefer. They need to be divergent. They need to be going from a slightly posterior to an anterior angle, because the anatomy of this fracture is relatively constant. And work from our units has shown that you're better leaving the wires proud and outside of the wound if you can. That decreases the risk of skin erosion and associated infection. Take the wires out at 4 weeks, but again, the child needs to stay in cast for 6 weeks. You can use screws, but often the metaphyseal fragment is too small, and therefore, if you're considering going through using a transcapitellar screw, there are big concerns over growth arrest, and there's no really good evidence that that doesn't exist at the moment. You're also condemning a child to a second operation to have the screw taken out. Complications, stiffness isn't too much of a problem with these children, and neither is non-union, provided that we don't have inappropriate treatments or a delay to diagnosis. Some children and parents complain of lateral prominence. That's often just callus, and we can reassure them. We need to make sure they don't go onto a malunion of cubitus varus or valgus. And obviously with any K-wire fixation, there's a risk for pin site infection. As mentioned, try and avoid posterior dissection, because if you do get AVN, the child can go on to get a fishtail deformity if the lateral trochlear ossification centre is affected. Moving on to Monteggia fracture dislocations. In 1814, Giovanni Monteggia described a radial head dislocation with an ipsilateral ulnar fracture. And the key to evaluating these injuries is the radiocapitellar line. At any degree of flexion or extension, that radiocapitellar line should bisect the capitellum. If it doesn't, you need to get a full forearm view and look for another bony injury. Also, don't be caught out by plastic deformation of the ulna. The normal ulna has a straight border. And if there is any bend to that border, then you need to be sure that there's no associated injury, such in this case where you can see the radiocapitellar joint is clearly disrupted. With regards to classification, people quote the Paed classification. However, in the papers, there's no real difference in treatment failure when you go via this classification. So while it can obviously be used to potentially in research papers, there's no great clinical use in my belief. And you treat these injuries by treating the ulna, and that will allow you to therefore indirectly reduce the radiocapitellar joint. And you need to use potentially an arthrogram if you need to, and II to prove that it's stable throughout its full range of motion. A paper in the late 90s came up with a good protocol for treatment, that if the ulnar fracture is incomplete, you can use an MUA and a cast. If it's length stable, so short, oblique or transverse in nature, you could potentially use an intramedullary device. But if there's any evidence of length instability, then you need to be doing an open reduction internal fixation. Later papers have proven that that's actually quite a sensible approach, and you can get good results with that method. And again, work from our unit in 2017 has further added to this and has come up with an instability index, which really highlights those injuries that we think might go on and cause real problems if they've not been meticulously planned out. So if you have two or more of a very proximal ulnar fracture, metaphyseal comminution, or an associated radial fracture, you know that that's going to be a tricky fracture to treat, and you need to be comfortable going into theatre with that injury. Complications, around 10% of cases can have an associated posterior interosseous nerve palsy. That's obviously associated with the degree of initial displacement, and that's unsurprising when you consider the proximity to the radial neck. Again, around 10% have a loss of reduction, and those injuries that are missed, unfortunately, then need to have a corrective osteotomy, plus or minus an annular ligament reconstruction. But thankfully, you can get good results with those, and that's also been published in the literature. So that's mainly the pathology that we'll cover. We'll now quickly just cover 3 RCTs that you need to be aware of for your exams. So first is the FORCE study. This was NIHR sponsored, as they all are. It was looking for splint versus bandage with regards to the treatment of torus fractures. This is now finished recruitment. Hopefully we'll have the results towards the end of this year or early next. The SCIENCE study is looking at non-operative versus operative intervention for the medial epicondyle fractures. And this is currently recruiting, so if you see any, make sure you get involved. And CRAFT is now newly opened. It's looking at off-ended distal radius fractures in 4 to 10-year-olds, and again, non-operative versus surgical reduction. Thank you very much.
That was a brilliant talk, James. I think there's some really nice and interesting questions which have come up on the Q&A aspect of the webinar. I think Chris and Chris have been answering that. But could you know, one of the exam questions which always keeps coming up is the pink pulseless hand. And you know, there's always this confusion about when to get a vascular surgeon involved. What are your thoughts on that one?
So we've got we're really lucky to have a fantastic relationship with the plastic guys who cover our vascular service at Old Hay. If there's a pink pulseless hand, I might give them a heads up that I'm going to theatre, but you don't necessarily need to have them in theatre with you. However, if it's a white hand where there's clinical evidence of poor perfusion to that limb, that's a different story. You're going into theatre with your vascular surgeon to make sure they can bail the child out of trouble if they've got a natural injury to the artery.
I think that's one of the questions which always comes up, isn't it? In every single interview, every single exam, whenever the supracondylar fracture comes into picture. There's a few more questions which have come up on the chat here. Lateral condyle fracture. Why is Milch 1 Salter-Harris type 4 and Milch 2 Salter-Harris type 2?
So from the Milch classification, I don't find particularly useful because it infers no benefit into clinical treatment options. So everybody reads the Milch classification because it's often the one that's passed down, but I would purely ignore it and just go with Jacob or using Vice. Some people use Song, but again, I think it potentially overcomplicates it.
There's a few more questions. I think we'll probably take one more question, and that's how much deformity can be accepted in a child with distal radius extra-articular fractures. So if we answer that, and then we move on to the next talk, and we can answer the rest of them just by typing, so you can all look at the screen. So
with regards to the distal radius fracture, I think that's hopefully going to be answered by the CRAFT study, which Mr. Dan Perry is hoping will provide answers to that. At the moment, if you're not part of that study, it's contentious with regards to the literature as to what's absolutely acceptable, and it varies with age. So to quote figures, I think is tricky. But there was a review article that was written by our unit in the Orthopedic and Trauma Journal in 2018, which will have that information in it.
Brilliant. I think maybe useful to move on to the next talk, and the rest of the 2 questions, or rather 3 questions, we can answer on the chat, because there are quite a few questions on this, so we can always come back to them if there are any queries. But in the interest of time, we'll move on to the next talk. Chris Pryor, over to you. Thanks.
Excellent. Thank you very much. Chris Pryor here. So I'm also left with the task of talking about a huge topic. And again, I'm going to boil it down to a few topics that come up in the exam and topics that are interesting really from a clinical context. So the old adage is that children are not just small adults, they are completely biologically different. And when you're looking at any fracture and how to treat it, you think about these 4 terms about trying to get good contact, alignment, stability, and then eventually the right kind of stimulation to allow healing. Now, of course, children's bone is much more biologically active, and the younger you are, the more like the lower the thresholds or the higher the thresholds are for each of these. But there are some special considerations. So let's look at the context of femoral fractures. This is an example of an 18-month-old that was brought in by a parent. They've been in the care of somebody else and sustained this femoral fracture. I would hope that one of the first things that will go through everybody's mind when they see this is to think, could this be a non-accidental injury? There are much higher rates in children under the age of 2 with femoral fractures, and some papers quote anywhere between 20% and 50% rate of non-accidental injury. So it's the first thing we should really consider, because they're typically low energy injuries, not like adults that require ATLS and stabilization. But of course, if the energy suggests that it's a higher energy, if the story suggests that, then you should be thinking along the ATLS lines. So the treatment options for younger patients are all based along conservative lines, and they all have advantages and disadvantages. In children less than 6 months, they heal incredibly quickly, and they're often very stable injuries because of the periosteum. So they simply need splinting, and the best way of doing that would be in this, which is a Paed harness. Once they get a little bit older, here is another option that can be used. So this is gallows traction, where the weight of the patient is used to apply inline traction to the injured limb. We'll talk a little bit about that afterwards. Now, different people will quote different ages and cutoffs, but roughly, if you think of it in the context of a child that is not walking yet, that's the kind of patient that would benefit from gallows traction. Certainly, if they're above 15 kilos or above 18 months old, it wouldn't be appropriate. Why is that? Well, it's because of the risk of going on to compartment syndrome. In slightly older children who are less than 5, the next options are deciding whether you want to do operative or non-operative. So all our patients that come through the door older here get a Thomas splint, unless it's an open fracture. And I would urge you to look at these guidelines done by the Royal College of Nursing about how to apply different splints, because if you're going to put a Thomas splint on a child, it could be that is their definitive treatment, because children heal incredibly quickly. If you want to think of a rule of thumb as to how long it takes for a child's femur fracture to heal, it's roughly their age plus 1 or 2 weeks. So if you have a 3-year-old, they may only need a splint for about 4 or 5 weeks. So our unit, we put them in Thomas splints into traction and counter traction to take the splint out of the groin. And when we see radiological evidence of callus, we take the traction off, we wrap up the splint, and we have a service where they can go home with the splint. However, there's no doubt that patients going into spica cast, which is what you see here, will get home a lot quicker. So let's just talk about gallows traction again. So the important things, if you're going to use gallows traction, so you need a cot. You need the kind of cot that will allow these contraptions to be added to them. The patient has skin traction applied on either limb, usually just with morphine and with a little bit of a benzodiazepine to stop muscle spasm. The idea is that you keep them so that their bum is just off the bed so that they are having the weight of their body go through the limbs, but not too much. And of course, as a safety aspect, you don't want any strings going wrapping around the necks. Whereas a spica cast, as I've already said, they have a shorter stay in hospital and they're a bit more mobile. Once the patient's parents and carers are happy with how to care for the cast, they can get home pretty easily. However, the disadvantages are that they must be put on in theatre, and they're difficult to manage the length stability of a fracture. So again, my preference is if a child comes with a long spiral fracture that or a transverse fracture that is already shortened, I would put them in a Thomas splint for maybe 5 to 7 days just to get rid of the muscle spasm, just to get a little bit of stability from early callus before I put them into a spica cast, because there are documented complications from trying to control the length using the spica. And Mubarak has a nice article about how to put on this, which is called the Harley-Davidson position, rather than the typical 90-90 cast that you see for DDH. And again, the other thing to note is that the foot is included, because if you leave it free, the puller gastrocnemius may pull on the fracture and cause increasing pain. The final thing to note about spicas is this, which is called spica syndrome. So that is where the cast constricts the gut, and if you get increased bowel gases there, it can press on the superior mesenteric artery, and you can get complications from that. What about the next category of patient, which is the sort of 5-year-old and above, that tend to be higher energy injuries? So in the context of this, I think a longer period of time in a splint may not be appropriate. So I always think of the cutoff age for me is really kids at school, because 6 or 7 weeks in a splint for this child would be pretty miserable, and for the parents, etc. So two treatment options here: internal fixation using either a plate or using intramedullary wiring. So what would you choose for which one? So in this scenario, this is a child who had an open femoral fracture and had some bone loss. So I was concerned about the length stability here with intramedullary wires. So I used this, once I'd debrided the wound, I used a minimally invasive submuscular technique, about a 7 centimeter incision distally and proximally, and slid a plate underneath. My other tip for you is, what size of plate should you use? Well, if the child's limb, if the child's femur is bigger than my own arm, I'll use a large frag plate. If it's smaller, I'll use a small frag, although I don't have a very big arm. This is intramedullary wiring technique. It's less invasive. It leaves less of a biological footprint. And this is the technique that we use. Another tip here: if you must go in an area that is preserving the growth plate. So we go about 15 millimeters proximal to the growth plate, so you're not injuring the physis or the perichondral ring. If you drill across at the level where you want to go, it means that your wires will go in at the same level. You still need a trocar to increase the hole size, and then you pass your wires. So prior to putting your wires in, you need to select the size of your nails. So the sum of the width of the nails should be between 60 and 80% of the width of the medulla. So each wire should be about 40% of the width of the medulla at the level of the isthmus. Okay, so you measure it on the x-rays and you go with that. You pre-bend the wires so that the forces are acting at the site of the fracture, which is why longer spiral fractures are inappropriate for wires, because when you put the bend on it, it will displace it. But this was one that works quite nicely. What are the contraindications? So this can get a little bit controversial. Certainly, it doesn't control length as well. However, Dupuis synthase offer these end caps, which will maybe push the indications a little bit more and give you a bit of length stability as well, because you push it on to the end of the wire and it stops it from backing out. Certainly, there's evidence and literature from the Korean groups that if you have a more proximal femoral fracture or a more distal femoral fracture, you do not get as good control with intramedullary wires, and they should be contraindicated in that case. Then the controversy comes about how old and how big they should be. So there was this paper from Moritz in the British JBJS 2011, looked at quite a few centres that were involved, and what they showed was that they had poor outcome once the age of above 11 or the weight above 49 kilos. So roughly speaking, that's the age that you want to be looking at thinking about alternatives. And certainly once they get above about the age of 12, it's much safer to be able to use solid nails, and they'll be much bigger. So here's a nice summary of the way that we treat them at Alder here. We tend not to use gallows, I have to say, but I've put it in there. So if they're very young, we use a Pavlik. You have all these options, but really you've always got the option of an external fixator for tissue loss. And for older patients, we go more for flexible nails and plates. So moving on, distal tibial physeal injuries, very common injuries. So we're always told that the Salter-Harris classification tells us about the risk of growth disturbance or forming a bar formation. So here is a very subtle injury. It's a Salter-Harris 2. It's only minimally displaced. So the classification would tell us that this is a low risk of going on to a growth disturbance. However, this patient was unlucky. And you can see here that the physeal started to close over compared to the other side. So one other key take-home message here is always have vigilance when it comes to physeal injuries. Now, when you get children who are a little bit older, teenage years, if they come in with a twisting injury to the ankle and they're tender at the anterior aspect of the ankle, always look very close for this kind of sign. So you can just about see it here. Oops. It's often called the Terry Thomas sign because it's like the appearance of the comedian with a gap in his teeth. So whenever you see that sign, look closely at the metaphysis and you can just about see a fracture line here, a Thurston-Holland fragment. So this is a triplane fracture. It's called a triplane because the fracture line runs in the coronal plane, transverse, and the sagittal planes. So why do they happen in teenagers as opposed to younger children? Well, it's all to do with the way that the distal physis closes over, and it's got this really cool way of going. So it starts centrally to close over, and you might just see a little area called Kump's bump on the x-ray where it just has a little lump there when it's just starting to close over. Then it closes medially. And then as it starts to close over, the final area not to close over is the anterolateral aspect of the distal tibia. So what's the clinical significance of that? Well, if you have an injury there, that's going to be the weak spot when they're older. And this kind of injury can occur. So the pull of the ATFL on that fragment causes this, which is a T-low fracture. So the take-home messages there are, if you have an index of suspicion that is an interarticular fragment, you must get a CT scan. These are all called transitional fractures, fractures that occur as the growth plate transitions into adulthood. Moving on to another topic, so open tibial fractures I want to touch on briefly. So here's a 9-year-old that came into our department with a high energy open tibial fracture. Now, going back to the beginning, we talked about how children are forgiving in terms of how well they heal in fractures. The one thing that they're not forgiving of, though, is that if you have a high energy injury that denudes the bone, strips the periosteum, and you've got dead bone there, the body ain't going to get rid of that. There's nothing in a child that makes them suddenly be able to get rid of dead bone. So this is reflected in the BWA-BAPROS guidelines for open tibial fractures, and the section on children clearly states that you should be treating them for their debridement in the same way that an adult does, even if what might appear to be a minor injury. So this is another example that I was involved with. This is a 4-year-old was hit by a car and had a 5mm open wound on the anterior aspects of the tibia around here. So people look at the Gustila-Anderson classification and get hung up about the wound size. So 5mm, does that come as a grade 1? Well, look at the fracture pattern here. Transverse fracture, both bones same level. This is a high energy injury. And the amount of the circumference of the soft tissues compared to the bone in children is much bigger. So the energy required for that bone to stick out through the skin is massive. So once we got this patient into theatre, they had periosteal stripping. So this is a higher energy injury. So although the wound was only small, we got plastics involved. We planned out the incision. Just this is taken from the guidelines as well. We looked at the perforators to plan our incision between the bone and the perforators. We took out the wound. We made a longitudinal incision and we delivered the bone ends, and there was dead bone just at the end. So we nibbled it back to bleeding bone. And my personal choice at that point was I put an Lateral frame on. So even though he was only 4, he did very well with the frame. He was able to walk in it pretty soon afterwards. So these children should be dealt with in an orthoplastic setting in keeping with the guidelines. Now, you don't always have to put an Lateral frame on. And here's a kid with a really nasty injury, another 4-year-old. Dashboard hit his anterior tibia. He had an open injury here. So we debrided him, and bearing in mind this leg's tiny, I was worried about putting a 3 or 4 ring Elizabeth frame on. It was quite late at night. So I decided to put the smallest half pins I could onto him. So you might look at this and think, this is bulky, this is massive, how's he going to get on? However, this is a little video clip of him. He was only 6 weeks down the line, and he was able to jump up and down on a trampoline, he was able to run on it. And this is before the fracture had united, because he healed in a typical way that a segmental fracture does, which is that the proximal part of the fracture healed first, and then the second bit took a bit of time. He was 4 months in a frame. Yuck. So this is a horrible injury. This is a 9-year-old who's got a distal femoral physeal injury, and this is a favorite of the exams because there's a couple of really important things here. Clearly, this is a high energy injury. So the physes around the knee are designed to withstand trauma. So your upper limb physes are usually quite smooth. Think of your distal radius. Think how often you see a fracture there, slipping through there. Whereas you have a big, thick perichondral ring around your distal femur. The physis is undulating. So the energy required to make this slip is really high. So that means the risk of a growth disturbance. But the main thing in this injury is that this is analogous to a dislocated knee. So the vessels are going to be kinked here. So you must treat this patient in the context of ATLS, and you must document the neurovascular status and then get into theatre early for a reduction. So this isn't my example, it's somebody else's. So they've used cross wires here because they want to respect the physis. If you're going to use wires to get this to heal, remember it's a high energy injury, it's going to take a long time for this to heal. K-wires, after about 3 or 4 weeks, exponentially increase in their rate of infection. So I would strongly urge you that if you're going to use wires, you bury them so that you can keep them in for longer. Okay, so this went on to heal. However, oh dear, this is what happens. Okay, so whenever you've got these patients, you must follow them up, and this can happen late down the line. So what's going on? You can't quite see the physis here. So there must be a growth disturbance. So the question you want to ask yourself is there a bar? How big is the bar? Where is it? Is it central, so it's going to potentially stop the whole limb from growing, or is it in the peripheries? And what has it done so far? So look at this, you can see the Harris growth arrest line here is no longer parallel to the physis. So that must mean that this is growing faster than the inside. So it's causing an angular deformity. So you would take a long leg x-ray and compare it to the other side as well. So ask yourself, if you were to leave it, what would happen? So in this context, the limb would start to go into more and more valgus, and you'd be into big trouble because he's 9 and he's going to grow for another 6 or 7 years. And then you ask yourself how much growth remaining. So you look at the age of the child, you might use other markers to look for bone age, you might look at how mature they are physically. So to decide the first stage, how big's the bar, where is it, you get further imaging, CT or MRI scan. So it's a bit controversial about how big a bar is before you can consider taking it out or not. So smaller and more central bars are more amenable to being removed than large peripheral ones. However, if you've got a really young kid, you're just going to do whatever you can to try and preserve growth, aren't you? So you might push the limits of how much you would take out. So it can be a bit complex about your decision making. So I've tried to break it down. You've got a child with a physeal bar from a trauma. So the first thing you want to know is, has it got an angular deformity? And if it has, your options are you can stick or twist. You can stick. You can do surgery where you stop the growth plate from growing. So you do a drill epiphysis, or you could even put an 8-plate potentially. I'd prefer to drill it because it's much more likely to stop it growing. And then you decide whether the angle is bad enough that you need to do an acute angle correction. So this is usually in the context of an older child, maybe a 14-year-old that's gone on, but they're not going to grow for an awful lot longer. However, if you're worried that this is a young kid and it's going to get worse and worse, you might say, let's go for it. Let's do a bar excision. But when you take out a bar and an angular deformity, you've got to try and correct it by doing a temporary hemi-epiphysis with an 8-plate. So you've looked at the angular deformity. Now think about length. So look at the limb length difference and decide what's going to happen if I do nothing. If they're a bit older and they can tolerate a little bit of limb length discrepancy, then that might be the ideal thing. Or you might say, right, they've got enough growth remaining that I'm worried, but they're predicted to be tall and they've only got a couple of years, then you might go and stop the other limb from growing to have to keep the limb lengths equal. However, if you've got a really young kid and that's not appropriate, then you might again go for a bar excision. Now, all of these treatment options leave you with the choice of being able to do a limb lengthening procedure further down the line. So think of it in the context of angular deformity, then limb length difference. And clearly this all depends on age and the amount of growth remaining. This is how you can take out a bar. This is the Langen-Skiel technique. Make a window in the metaphysis, use a burr, try to do it low energy. You drill it all until you see the physis. They use a dental mirror. Most people use an arthroscope. But what you must do is fill it with something that's going to stop this from healing, like a fracture. So here's one that I did. We put an 8-plate on the side that had overgrown. And this is the undergrown side. Use the KY. We're fortunate to have intra-op CT to be able to place where the Y was. Over drilled it. Use the curette, and then this is what we did. We put a dermofascial graft in there, and I put clips in it so I know that the fat is where it should be. And then I shoved a blob of cement in there just to keep it all in so it wouldn't move out. Okay. Finally, just to end with, growth disturbance isn't all just about stopping growth. So if you get a fracture in the proximal tibia, it can cause a stimulation in overgrowth, and this is called Cosen's phenomenon. So be aware of metaphyseal fractures causing this phenomenon. Often they get better. This is quite an extreme one, and I suspect this one probably went on to have hemiepiphysiodesis temporarily to straighten the limb. So let's do a summary. So in summary, always remember non-accidental injury in any fracture, but particularly young kids with femur fractures. Treatment of femur fracture depends on the size of the child and the stability of the fracture. Open fractures, please think of them in terms of adults and how you would do it in an adult in terms of the debridement. In terms of transitional fractures of the ankle, always think of those in teenagers. And physeal bars all depends on assessing the size and position of the bar and seeing how much growth there is remaining. Thank you very much.
That was a really nice summary of lower limb trauma. I think such an extensive topic, and you highlighted the really important ones for the exam. Really nice. There have been lots of questions which have been coming in, and Chris Talbot and James have been answering them. I think one of the things which if I remember correctly in the exam, which is asked quite a lot, is about the triplanar fracture, isn't it? And also, you know, there's this question about implant removal, and there's such a wide variation across surgeons about when to remove implant. What are your thoughts on that one, Chris? Sorry, you're on mute, my friend.
They're controversial, without a doubt. They're intra-articular fractures, so you think of it in terms of how much displacement there is. There was a Mexican paper from years ago that said that if there's more than 2 millimeters displacement on an X-ray, they'll go on to early away if you don't do anything. But in the context of intra-articular fractures, you want to reduce it and get good stability and early mobilization. And there was a paper from Canada that suggested that if you leave a screw in the distal just above the plafond, it increases the stress, a stress riser there in terms of causing early away. But that was an in vitro study rather than in vivo. I generally leave them in. I've not seen them cause problems. I've looked extensively at ones that we've done, followed up, looked at 60 of them from our unit. There was only a couple of complications and nobody went on in the first 5 years to have any issues. In the context of generally removing metal work, it's patient choice really. If they're very young and it's going to cause an issue, I'll take it out. Certainly with plates and wires, there's an increased risk of stress rises, particularly if they're a gymnast or, you know, they like to do motocross or something crazy like that, then I definitely would counsel them for removing the metal work.
Of course, I remember as a senior, this is going back a long time ago. So when the boss is on leave and you're doing the list, he'll leave a tens nail in there for you. It's been in there for a year. So you have fun finding the ends. There you go. Right, I think there are no more unanswered questions. Most of them actually been, no, there are actually a few. They're again more related to upper limb fractures. So we'll come back to that. I think we move on to the final talk of the evening. Chris Talbot, who's again a colleague from Alderhay. Chris, over to you, my friend.
Okay, thanks. So the final straight, I've got 20 minutes, I think. So I'm going to talk to you about SCFE, DDH, and I'm Chris Talbot. So SCFE, we don't really know the true incidence of it, but the literature states that it's really around 2 to 10 per 100,000. We know that there's anatomical, histological, and mechanical roles in the disease process. And one thing that we know is that in the normal patient, the physeal is made, the zone of hypertrophy is made up by about 15 to 30%. But in those patients with SCFE, it can be up to 80%. And this is where the abnormality in typical SCFE occurs. You get abnormal cartilage or development around this area. and also with associated perichondral ring failure, you end up with your SCFE. We know that shear force is imparted to the physis kind of proportional to the weight or the body weight of a patient, and so we know that one of the risk factors, or one of the risk factors, sorry, for SCFE is that of obesity. In terms of anatomical problems, you just need to know about retroversion of the femur as well as the acetabulum, as well as the abnormal inclination of the proximal femoral physis. So how does a patient present? Well, they can present with weight bearing, non-weight bearing. They can have a short externally rotated limb. They may be limping. They present with thigh pain, knee pain, which is more important for me sometimes than hip pain. And it's really important not to miss out the hip when somebody's presenting with thigh and knee pain. In terms of the clinical examination, they have a positive Drenham's sign, which is when the patient's supine, you flex the hip up and they have that external obligatory rotation. So we can classify it in various ways. Loader, which I'm sure you all know about, is the stable versus unstable, whether a patient can weight bear with or without crutches, or non-weight bearing, and what the implications of these are in terms of avascular necrosis. And the original paper stated 0 to versus 47% with the stable and unstable slips. You've got the age of onset, so acute, chronic, and acute on chronic. So less than 3 weeks, more than 3 weeks, acute and chronic. And then Zibarth and the surgeons in Bern described an intraoperative stability, in which they talk about physeal stability when they've actually got the hip joint open. And they did a nice little paper that showed that actually the correlation between intraoperative stability and Loader's classification isn't very accurate. And that's certainly something that I find when treating patients with SCFE. So how do we radiologically grade it? Well, you can do it in just simple degrees of slip. So mild, moderate, severe. Is it less than a third, more than a third, and between, sorry, a third and 2/3, and then less than, and then more than 2/3 of the epiphysis on the slipping on the metaphysis. You've got the Selfis angle, which looks at the angle that subtends or is perpendicular to the epiphyseal angle and the axis of the diaphysis. And what you need to know is that with a Selfis angle, you must measure the opposite side, and it's normally between 10 and 12. And sometimes if you have bilateral slips, you take 10 to 12 degrees off the angle that you measured on the opposite side. So what are the radiological features? So it's a bit of a poor X-ray, I'm sorry. The green line is Klein's line, and the Klein's line is a line that runs along the superior aspect of the proximal femur, and it should intersect or transect part of the proximal femoral epiphysis. Trefauen's sign, which is positive when this does not happen, as in this case. Capen's sign, as the SCFE occurs, you get lateralization of the medial aspect of the proximal metaphysis. And so what happens is this does not intersect, or the posterior acetabular rim does not intersect this, and that's Capen's sign. And then you've got Steele's Blanche sign, which is where, because the overlap of the femoral head, or the epiphysis, sorry, with the metaphysis causes an opacification within the metaphysis. Other radiological signs include increased distance between the teardrop and the metaphysis. You get remodeling signs in chronic or more delayed SCFE, so you see sclerosis and callus. You get decreased epiphyseal height and widened irregular physis. So how do we treat SCFE? So stable SCFE, mild and most moderates, the gold standard is pinning in situ. It's really important to ensure that you realize that the entry point for most slips is more anterior in the neck. So on the AP and the lateral views, you triangulate your entry for the screw. People use 6.5, 7.3 millimeters, full threaded, partially threaded, stainless steel, titanium. One good screw, must be 5 screw threads through into the physis, and ensuring not to penetrate the joint. If it's a severe stable slip, it's very difficult sometimes to pin in situ, sometimes impossible. But if it is possible, there are several options. There are 2 options really. So the options include pin it in situ and then delay a secondary and perform a secondary realignment procedure, which is the top part, or you can proceed to a primary corrective osteotomy. And the osteotomies can be subcapital, basocervical, or intertrochanteric and subtrochanteric. And then what you've got to do is you've got to weigh up the risk of, do I correct at the cora? But then there's a greater risk of avascular necrosis. So these are the things that you've got to discuss with the patients and the parents. So in an unstable slip, the AVN rate is higher. It's really important if you have an unstable slip that you transfer these patients to centres where there's expertise and equipment available to perform the procedure. The types of surgery and the interventions are still controversial. However, the trends seem to support still open surgery rather than closed reduction or pinning in situ. So how do we treat the unstable slip? So you've got open reduction, internal fixation. This can be through an anterior approach or a Watson-Jones lateral approach. Parsh actually described a Watson-Jones approach in which he goes through and uses his magic finger, thumb, and reduces the slip and pins it, and he pinned it with wires. I think he reported an incidence of AVN of 5% in his series. Nobody's been able to report AVN rates better than that using Parsh's technique. The other option is to perform surgical realignment at the subcapital region. So this is a surgical hip dislocation. You don't have to perform a surgical hip dislocation to get to the hip. You can perform an anterior approach. My preferred method is a surgical hip dislocation and a modified Dunn osteotomy using a extended retinacular flap. So another thing that you need to know about the unstable slip is this unsafe window concept. For me, you need to get to a SCFE within 24 hours, if not delay it. There was a paper by Al Schreider, a patient level analysis, which looked at over 300 unstable slips. And he showed that by under 24 hours and over 72 hours, the AVN rates were about 15% for the unstable slip. That time frame between 24 and 72 hours, the AVN rates were 40%. So finally, just on SCFE, pinning the non-slip side, so the prophylactic pinning. There are surgeons that will pin everybody. There are surgeons that will selectively pin patients. The most important thing is to have a discussion with your patient and the families. There is not a 0% risk of doing a contralateral prophylactic pinning. There's about a 5% risk of AVN chondrolysis and fracture. I take a selective approach. Children under the age of 10 have an increased associated risk of SCFE. Patients with renal dystrophy or the endocrinopathies, I tend to contralaterally pin. Patients who you anticipate where there's a poor compliance for follow-up, I offer pinning. There are other things such as the open triradiate cartilage, the posterior slope angle, and also the modified Oxford score, which people use to try to work out whether to pin the slip or not, pin the contralateral side or not. So that's essentially SCFE in a nutshell. Moving on to DDH. So the incidence of DDH is about 1 to 2 per 1,000. There's an NIPE clinical screening program, which is clinical and ultrasound screening. So there's a 72-hour examination, clinical, which involves an Ortolani and Barlow maneuver. The Ortolani test is a test of reducibility. So it's abducting the hip and placing pressure on the lateral aspects of the trochanteric region and reducing the hips. Barlow is a bad man and he dislocates hips. So it's a test of dislocatability. So it's adducting the hips and placing posterior pressure or a posterior force to dislocate the hip. Risk factors that need an ultrasound scan within 6 weeks are breech and family history. So how do you know the hip's in? Well, with an ultrasound scan, you need to see a centered hip with an alpha angle of greater than 60 degrees. On an X-ray, what you're looking for is several features. You need to draw Hilgen-Greiner's horizontal line through the triradiates, and you need perpendicular Perkins lines, which come down the lateral aspect of the true acetabulum. So once you've done that, you can determine whether there's a displacement of the femoral head, if there is an ossific nucleus, and it should sit in the inner inferior quadrant, but as you can see on this X-ray, it's in the upper outer quadrant, dislocated. You do see asymmetry in the ossific nucleus, and sometimes it's not present. There is a break in Shenton's line. There's a pseudoacetabulum, and the acetabular dysplasia is determined by seeing an angle of more than 30 degrees. So if it's not in, how do you make it stay in? Well, there's different options. You can put them in a Pavlik harness, you can do a closed reduction and spiker application, or you can perform surgery. So this is our DDH management escalator. As you can see on the left, we have the least invasive procedures, and as you go up the escalation, you increase your amount of surgery that you need to consider performing for the child. So with the Pavlik harness, it limits adduction and extension to within the safe window, so the baby is in a flexed abducted position. There are complications to Pavlik harness, and it's important to note that and to inform the parents of this, such as persistent dislocation in a harness, AVN rate, and also femoral nerve palsies. So if you've trialed the harness and it's not worked in a type 4 dislocated hip, I don't want you to try for more than 2 to 3 weeks. You need to check weekly that the hip is starting to reduce or is reducing. And after 3 weeks, if the hip's not reduced, then you need to consider going up the escalation ladder. So when you do a closed reduction, what are the prerequisites? Well, the prerequisites of a closed reduction are concentric reduction, do an arthrogram, make sure that you have no medial dipooling or minimal medial dipooling. We know that more than 7 millimeters of medial dipooling leads to worse outcomes and increased risk of avascular necrosis. You also want to know and need to know about the window of Ramsay's or Ramsay's zone, which you need a wide safe zone. So such that you can place the patient in a comfortable abductive position without the risk of knowing that the hip's in maximal abduction to cause AVN or maximal adduction to lead to dislocation. So what are the indications for an open reduction? Well, if you've not got a wide safe zone and if your hip's not concentrically reduced. So what are the options of open reduction? Well, you've got a medial open reduction, and this is performed earlier in the infancy, in childhood, and we normally do this up to about the age of 12 months, but it does vary between surgeons. There are some contraindications and disadvantages, such as high dislocations, infolded labrums, those babies that are over 12 months, patients that require additional osteotomies. We know from the literature that the AVN rate is high, and as you can see, the medial circumflex vessels can be affected. We know that 1 in 5 children seem to have a poor, or it was reported by Sackers that they had a poor clinical radiological outcome. So what are the advantages to an open reduction anteriorly? Well, it's more familiar territory. Capsular repair is feasible. You don't repair the capsule in a medial open reduction. If you need to do a pelvic osteotomy, you're in the right place, and it's necessary for high dislocations and teratological hips. What are the disadvantages? Well, it's a more extensive approach. If you've already done an anterior open reduction and you've staged a pelvic osteotomy, then you've got scar tissue to get through, which can be sometimes difficult. So why won't the hip go back in when you've performed an anterior open reduction? Because this is something that you will be asked. Well, there are extrinsic and intrinsic factors. The extrinsic factors, so tight psoas, adductors, hamstrings, and rectus femoris. And the intrinsic factors, you have your arrogas capsular constriction, the labrum inverted or enfolded, transverse acetabular ligament, the hypertrophied ligamentum teres, and the pulvinar. So coming to the end, moving on to the role of pelvic osteotomy. What is the aim of the pelvic osteotomy in DDH? Well, it's to improve the femoral head coverage and to improve the coxofemoral joint stability. There are different types of osteotomy, which I'm not going to discuss at length tonight. But the concepts are that of a reorientation or a redirectional approach, osteotomy, the acetabular prostheses or the volume reduction or reshaping osteotomies, and the salvage procedures. There's a nice paper by Chen which gives a lovely summary of pelvic osteotomies for DDH. I'd advise that you give it a read. But essentially, as you can see, there's lots of different osteotomies described by lots of different people. I think in terms of the exams, you need to know about the redirectional and the volume altering as well as the salvage procedures, and maybe know one or two of them. If the hip is not concentric, then you do need to consider Chiari's and shelf procedures. But all the other options that are stated on this slide, normally in older hay, I would go for a Salter osteotomy and a triple osteotomy in the older patient with an open triradiate, and then with a closed triradiate, a Ganz osteotomy. So the final slide, it's really important with DDH that you maintain and observe your patients until skeletal maturity if you have operated on the patients or you know they have DDH. And the reason for this is because there is the risk of residual dysplasia, and that's it.
That was again another fantastic talk. This topic is so important for the exam, isn't it? It just keeps coming up. I think it's probably one of the top most important questions to be asked in the exam amongst all the subspecialties. So, and your talk really covered it so well. Thanks for that. Chris Betherton, I need to specify which Chris, isn't it? Chris, do you have any questions for the panelists as a trainee? What things you'd like to ask?
Yeah, so just look, again, you've answered most questions, and that's all lovely and understandable. So I think there's one here from Atif Amoon I've just seen about why do you not do an open reduction after 12 months? Was that by and you said you can and you can do and some centers do, or was the question, do you think, why don't you do a medial approach over 12 months? Is that what I understood? Was that what you were saying?
Yes. So if you look at most patients over the age of 12 months, or when they start walking, the dislocations are higher. You will struggle to achieve a closed reduction with a medial open. A reduction with a medial open reduction, and it's really, I would be looking at doing an open reduction to know that I could get the hip, an anterior open reduction to know to get the hip reduced.
Good. And why wouldn't you just do an anterior in a 2-month-old, for instance? Just
okay, so that's not a bad question. In a 2-month-old, I would at least try a Pavlik harness if it was dislocated. But you're quite right. Patients do have anterior open reductions at the age of 3 months, but it's just the way that I've been trained, and we use the medial open reduction.
So if I'm in the exam and I want to say I want to have one answer, DDH done, should I just say, can I just say the anterior approach no matter what age, and I won't then get myself into trouble?
Yeah, so you can do an anterior open reduction for all patients.
Great. And then there's another one here about physeal distal humerus physeal dislocations, and the difference between that and an elbow dislocation. And so I guess you mentioned you can look at radiocapitellar alignment, but I guess the question is, if they don't have that capitellar ossification, is there a way of determining it, and is it relevant, or do you not get posterior? Do you not get dislocations of the elbow at that age?
If that's the case and there's no capitellar ossification centre, then it really is difficult. But in children that young, then they don't really get elbow dislocations, and it's often transphyseal. And if that occurs, then you really also need to be thinking about NAI. So it's not just the elbow injury that you need to be looking at.
Okay. And I think that was it. Probably just go back to the chat now. See what there's another 11 to go.
I think the questions have been coming thick and fast in this session. It's really nice how this is caused a lot of raised a lot of questions. Excellent. That's what we want.
Do you want me to start answering some of the questions that have come through?
If you want to take one or two representative ones, then we can start.
Yeah. So how to decide a treatment option for acetabular dysplasia based on age of presentation. So if you look specifically at acetabular dysplasia, Tonis has a beautiful graph which outlines the normal, mildly, moderately, and severely dysplastic hips. Normally, at the age of 4 or 5, I would expect the acetabular index to improve, and we work off if the patient has an acetabular index of more than 30, then this is something that we would consider doing an osteotomy, a pelvic osteotomy for a patient at that age. The other thing to say is that when you get into the 25 and 30 degrees, again, a discussion needs to be had with the parents about whether to proceed with an osteotomy or not. But anything less than 25 degrees in a patient with who's 4 to 5 years of age, I'd probably keep an eye on and observe it.
I think what we'll do at this stage, as we keep answering the questions on the screen, I might just launch the question and answers towards the end, the MCQ, end of session MCQ. That'll take us a while to get through as well. So what happens now, I'll launch the poll. Hopefully everyone can see all the questions coming up. So these questions are related to all the 3 talks. And if you could all start answering those questions, and as we go through those questions, it'll take a few minutes, and the panelists can keep answering the questions on the screen in the meantime. We'll give you a few minutes to answer these. You can scroll down as you've done in the last many sessions. It's the same thing. There'll be about 10 questions. Give it a few minutes for all the attendees to answer. Some really nice practical questions there. Something you'll do, which will come up in the exam, see every day. You can see the answers are now coming in. We'll give it another couple of minutes before we close the poll. Just so everyone knows, this session's being broadcast live on YouTube. Also, all the previous sessions are on YouTube on the Wrightington Upper Limb channel. So you can go back and look at it as many times as you want. Okay, we'll give it another minute or so before closing this poll. think half the people have answered, roughly. Okay, we'll give you 1 more minute and then we'll close the poll. So those who haven't submitted, please do, and then we can discuss the answers. You should have the question time TikTok in the background, isn't it? Okay, we're closing in 10 seconds. Okay, there we are. Right, so here we are. So we'll just share the results. There we are. So shall we start with your questions, James? The first 3 are your questions, aren't they? So if you could talk us through those questions and discuss those.
Yeah, absolutely. So with regards to neurovascular injuries and subcondylar fractures, which of the following is false? Majority have got this one correct. So the median nerve injuries are most commonly associated with posterolateral displacement. We've covered that. Ulnar nerve injuries are most commonly associated with flexion type injuries or grade 4 extension type. Radial, so that was the correct answer. That's false. Radial nerve injuries are most commonly associated with posteromedial displacement. And the brachial artery obviously travels with the median nerve, so that's with the posterolateral displacement. And there's a nice paper from Benjamin Shaw in JPO in 2017 that showed 90% of nerve injuries recover spontaneously within 6 months. Moving on to the next question, the OK sign, looking for AIN. We all know that the AIN supplies 3 muscles. It's the FDP to index and middle finger, the FPL and PQ. So therefore, if you work through those answers, it's FDP to index and FPL. And with regards to which ADA radiograph shows displacement most accurately, Song in 2007 showed that this is internal oblique view, and in the presentation that was hopefully demonstrated clearly on that series of films.
It's brilliant. Is it Chris? Chris, your turn now. Chris Talbot.
Hello, sorry, I'm trying to answer the questions.
Right.
So we're at question 4, yeah?
Question 4, yeah.
Okay, so which of the following would not be present during clinical examination of a unilateral irreducible dislocated hip? 74% of people answered correctly. So you would not expect to see an Ortolani's sign. And the reason for that is Ortolani's test is a test of reducibility. Now, clinically, the hip is irreducible, and therefore you would not be able to detect a positive Ortolani's sign. The rest are perfectly plausible. You would expect in a dislocated hip to see limited hip abduction, leg length discrepancy, a positive Galeazzi sign, and a short leg gait. The following radiological and clinical signs have been described as an aid to diagnose SCFE. So 58% got the correct answer. So Trethowan sign, Capeness, Steele's are radiological features which we discussed in the talk. The subchondral crescent sign, or the Eade crescent sign, is almost like similar to that of the talar neck fractures and this Hawkins sign that you see with that, where you get subchondral osteopenia, which is a sign of revascularization. Dremann's sign is the flexion and obligatory external rotation of the hip when placing it into flexion on the patient supine. So you would clinically see that if they had a SCFE, or you may well see that. SCFE occurs through which part of the epiphyseal growth plate? Perfect. So most people got that right, as we talked about the hypertrophic zone. There are some the renal disease patients that it does occur in the spongiosum, but the majority, so the typical patients, it would be in the hypertrophic zone.
That's brilliant. Thank you. I think the final 4 questions are your, Chris Pryor.
Indeed, yep. So the question number 7 is about gallows traction, and I think pretty much everyone got it. So the relative contraindication is weight over 15 kilos. It's ideal really for length unstable fractures and kids under 12 months, and the others aren't necessarily contraindications. Number 8 was really just to push the point that the debridement aspect of it in children should be followed according to both guidelines. Now, in terms of fixation, it is controversial. There's often talk of, I think Deborah Eastwood came out with a paper recently that said that you don't necessarily need to fix lower the fractures, but I don't think there's much doubt that, worldwide, you've got roughly about a 10 to 12% risk of a deep infection, probably somewhere between 5 and 10% risk of a non-union as well in children's open tibial fractures, so they're a tricky beast. Number 9, what describes so in terms of elastic nailing. So the first one was a slightly sneaky one because it's the diameter of the medulla rather than the cortex at the site of the isthmus, and it shouldn't be the site of the medulla at the site of the fracture. It's to do with where the isthmus is, so how narrow you can get, how much you can shove into it, basically. So that paper we discussed by Moritz said that children over 49 kilos is a relative contraindication, and age over 11 rather than 8. And then finally, we talked about how the physeal closes in the distal tibia. So it follows this one, which is central, and then it goes to medial and then lateral, with the anterolateral tip being the final bit, which is how you get the tilo fractures.
That's brilliant. Thank you. I think the audience has got most of the answers right. That's excellent. So you guys are well prepared on your way. So Chris Bretherton, do you have any questions before we close the session? Anything else you wanted to ask on behalf of the audience?
No, yeah, I think you've answered all the questions. Some of them have been asked, have been duplicated, and they've been answered elsewhere. There's just 2 or 3 you may want to finish up with, or leave it there, because I think some of it was covered in the talk, and if they go back on YouTube, they'll see some diagnostic treatments for acetabular dysplasia and various things.
Yeah, I agree. I think it's been a fantastic session. All 3 talks so relevant, so precise. It's a huge topic, and to cover it all and concise them in such a short time is fantastic. Thanks everyone for your lovely contribution. Thanks everyone for joining us. I think we're taking a break next week, and hopefully see you later. Thanks. Bye-bye.